So here are some of the common geriatric, depends on what you read, what you'll see in the literature, but the most common are falls, urinary incontinence, pressure wounds, malnutrition, delirium, and then frailty. And when we look at frailty, it's considered the core geriatric syndrome. And the reason for that is because it really, when they're frail, they're at higher risk. It really has such a high impact on them. And I have to put my book up there. I'm the editor, and this textbook for nurse practitioners, Adult Gero, and this is where I got that. We have a chapter on geriatrics in there as well as pediatrics. So it's characterized by that physiological decline in multiple systems, and it results in that diminished muscle strength, decreased endurance, and unintended weight loss. It affects them across social, emotional, spiritual, physical, psychological. So you have to think about when they present with frailty, it's going to multi-system effect. So you can see it's a dynamic process that occurs along a continuum. And if there isn't some improvement, it's going to get worse over time. And you can see it's a physical domain as well as psychological and then social. One of the things that's emerging in geriatrics is the significance of social connection. It's not socialization. So if we're all in a room and we're all in a room together, we don't talk to each other, but I'm sitting in the corner, that's not social connection. And that really is not. It's social connection where you are connecting with others and talking. That is linked more highly to morbidity and mortality, and it's coming out more and more in the literature. So, for example, we suffered this hurricane in Florida, as you heard earlier, and all of you know. And so when you're in a community there, what about these older people that are isolated? You know, how about them? What's going to happen to them? And so it's really important when we think about older people living alone. It's not loneliness itself is a predictor of poor health outcomes. But when you talk about not even connecting with others, not doing anything, and we've got many older people that are in those situations. So for example, like last night, Deb and I were on the phone with one of my neighbors in the community who's almost 80 years old, who felt my partner, he went to the house and saw her, and she was very pale. She had taken her metoprolol, lorazepam, what else was it, Deb? One other pill, PPI, Protenex, and then all of a sudden her stomach bothered her, and you're laughing because you see this all the time, I know, and her stomach bothered her, and he said when he got there, she was almost white. So he called me, so she got 2 for 1. She got Deb and myself there. We were talking to her. And she's taking these pills all at once, and she's got a new onset of atrial fib a few months ago. They're treating that, but if it wasn't for the neighbors, so when I called them this morning, there was one neighbor bringing her food, one bringing her to the doctor. He went and checked on her. So there are community that check on people, and that's very important to make sure that they're okay, because we have more people living in the community that are 65 and older than we do in nursing homes. So we need to think about those people living in the community and what their needs are, and how do we reach out to them. There have been nurse practitioner practices where I have several students who graduated and have gone out and opened their practice doing home visits. But we need to think of those patients with CKD. How do we reach them? How to reach our older people? What happens when they leave a dialysis center? You know, some of the older people prefer hemodialysis because they can socialize. That's their way. That's the only time they do. So talk about the epidemiology. The incidence is about 1 in 6 in community dwelling older people. Females, lower income, racial and ethnic minorities have the highest risk, lower income countries. And we have something called pre-frail, which is they're not really meet the criteria for frailty, but they're really starting to experience some of those signs of it. So you'll see, and I'll talk about them in a minute. So we can see that it's not, but when we look at nephrology, and we look at CKD, and we look at people on dialysis, it can be, the literature says, anywhere up to 80%. When you get a wide range of 40 to 80%, you know that there's more out there that we're not counting. We're just not capturing the entire population. So you need to think about what are these people on dialysis that are frail. And that's a high percentage of them, particularly as we see this older population on dialysis. And so if we look at CKD, and we know that there's worse outcomes compared to those that are non-frail, all these things I said earlier, but in CKD, there's a faster progression to death. I mean, to end-stage renal disease, and then, So they have a faster progression of CKD with frailty. So very important in the community to identify frailty. A transplant is a big issue right now in transplant. Anybody transplant coordinators here? Okay, so you can contribute to this if you later on and give us some feedback. But it's very important because do you transplant these people? And so I went to a conference one time, and a transplant nephrologist was talking, and he said that he always does a frailty instrument measure before he decides if an older person is going to receive a transplant. Because if they're frail, the success of that transplant is minimal. And so very important, and they have used there's a multi-center prospective cohort of frailty where they use the Freed, and I'll talk about the Freed frailty measure, and then a registry for transplant. And what they found was, not surprisingly, that frailty exists in our population, and many of them were frail at the time of evaluation. And it was more of them that were the non-living related donors that had a higher risk of frailty. And that makes sense, because if you're doing a living donor, you're already assessing them, you're looking for these things. And then these other patients, you're getting them when they meet that criteria, when they have the donor. So it's a very high, and I think we'll see even more. If you think about it, if I tell you there's almost 80% on dialysis that are frail, how many more are coming in that are on transplant that are frail, right, that want a transplant? So this is a little bit busier, but I wanted to just show you, when you're looking at frailty, the complexity of frailty. It's very complex. And so you think it's a combination of genetic factors, environmental factors, multi-system dysfunction, and the manifestations of the disease you can see in the middle. So there's the consequences are those that are vulnerable, because if you have cognitive impairment, you're vulnerable. If you have physical decline, you're vulnerable. If you have multiple comorbidities, you're vulnerable. So looking at some of the vulnerability of these patients and what some of these things can happen to them and how they respond. So it's really at that cellular level, as well, as you can see on the right side of this. So it's really that there's some bi-directional, as you can see by the arrow there, that in the relationship between other contributing factors and then the progression of frailty. I think about my early nursing. We used to always say, oh, that person's frail. We didn't even know what we were talking about, but we used to say it all the time. This might be a little easier for you to see, because when you look here in the non-dialysis, once again, that progression of CKD, hospitalization, death, the kidney transplant, the risk of death after getting the transplant is higher. She's shaking her head, so I'm right on target, thank you. And then either that risk for rehospitalization. When you're looking at end-stage kidney disease, you see that there's decreased quality of life, dialysis withdrawal, decrease in their cognitive function, and their quality of life is very important. So what are some of those risks? I love her hair. Don't you love her hair? And she's so pretty, isn't she? So I just had to put her up there because I think she's beautiful. Pardon?
To me, as a nephrology NP, general NP, she takes pride in herself. She has confidence. She's got her jewelry on. Just looking at her face, I can assess so much.
Yeah, you can, exactly. By looking at her, she's happy, she's doing well. So she doesn't have frailty, obviously. So I thought that was good. It's so complex. Like, you got arrows, everything you get, this relates to that and that. It's not just a simple thing, but you want to always think about physical function. When you care for older people are not afraid of disease, because if we look at the statistics, most older people, and I hate the word when you're 65 and older because it's too close to home, but you want to think about those people. You can have someone who's 90 who's worse, and somebody who's 40, and that 40-year-old is worse off than the 90-year-old. And you see it in dialysis all the time. So you think about those younger people. But when you look at older populations, you have to think of physical function, because they're not fearful of a disease. If you look at, like I was saying before, if they have, most older people have 2 or more chronic disease. So they live with disease, that's not their fear. It's their independence. You taking away things from them. So when they have physical decline, they may not tell you, oh, I'm really feeling more tired. They may keep it a secret from their family because they don't want anybody to come in and take over.